recent nightmare for dental fraternity, because we know that the patient first comes with a foul smell or mobile teeth. So we don't know whether to extract the teeth or send it to the ENT, or we have to do it yourself. So today this webinar is going to highlight the basic concepts needed to identify and adequately treat mucormycosis in its initial stages to prevent morbidity and mortality associated with dreadful disease. So let's join this informative session where we can learn the basic concepts and criteria for early management of this complex situation. So I now welcome Dr. Khadar Wali Sheikh sir, who's PhD, MDS and FICOI. He's also a senior consultant in oral and maxillofacial surgery and has frequently managed aka black fungus. Sir is also an eminent speaker in the field with many national and international publications to his name, and he has authored many chapters in world-class textbooks coming in maxillofacial surgery. And sir is also an excellent orator with a passion to learn every day and share with everyone. So let us learn from the speaker's expertise and upgrade our knowledge. Welcome, sir.
Thank you very much. Can you hear me?
Yes, sir, you're audible.
So, is everyone here, or we need to wait for some time?
We can start, sir.
Okay. So, hi, welcome everyone. So, we'll have a small discussion about the present tsunami post-COVID-19 management, which is mucormycosis, also known as black fungus in recent times. So, what is this mucormycosis, or what causes this mucormycosis? It's also known as zygomycosis because of the family Zygomycetae. Basically, it's an opportunistic fungal infection which is always present in our environmental conditions. So it has different ways of action, basically involving different tissues of the body. Am I audible? Is everyone here? Or need to wait for some time because I don't see anyone here. Is it fine? You can see the screen?
Yes, sir, you're audible. Yes, sir, the screen is also visible.
Okay, fine. So, based on these clinical forms, there are pulmonary, gastrointestinal, cutaneous, cerebral, and rhinocerebral mucormycosis. So, as far as dental fraternity and maxillofacial area is concerned, we are in a well management of rhinocerebral type of mucormycosis. So, as the name suggests, rhino, sinus, and cerebral, which involves the brain or head and neck areas of the body. So, basically, what happens in this mucormycosis, which is characterized by tissue necrosis due to invasion of blood vessels. So, we will in detail go into the action or how this pathogenesis of this mucous species is going on, and what is it to do with a patient with COVID-19 recovery. So, what happens in COVID-19 recovered patients, and what is this fungal infection? How is it coming from? Where is it coming from? So, how do we manage these patients? What is the morbidity of this patient? And all these things. So, if you have any doubts or if you want to discuss anything, you are most welcome. Okay. So, mucor and order mucorales, there are different fungi which are present in this order. Variabilis and Lichenia, Rhizopus, Rhizomucor, and all these different variety of species are there. These are the most common environmental organisms. So you find these organisms everywhere in our surroundings. So these are always there. They were always there with us. So they were not harmful for any human being before. But if the patient or if the person is immunosuppressed, if the patient is not immunocompetent, these fungi take a role into or they convert themselves into opportunistic infection. So what happens in this immunocompromised? How does this immunocompromised state of the patient comes? Basically, when these patients have recovered or have recovered from such immunosuppressive disorders or patients with severe COVID-19 recovery patients, basically who were on steroid therapy, prolonged steroid therapy, people who were on anti-cancer drugs, chemotherapy, and patients with organ transplant patients who will always be on immunosuppressive drugs. Okay. So the viral steroids are basically because of why are these fungi so aggressive? What happened? Why is these fungi affecting the humans so rapidly in these immunosuppressive patients? Because fungi has the spore size or the seeding size or seed size of the spores are very small. It's usually from 3 to 10 micrometers size. And once the spores are, and these spores are thermotolerant, they can sustain body temperature around 37 degrees. And once the spores are implanted, after that, the property of isopores, the property of fungal infections is iron acquisition. They have the capacity to take this iron from the blood or the heme. So that is why the main angioinvasive property of this fungus. This explains the aggressive nature of this fungal infection. So the risk factors, usually patients with immunosuppression and hematological malignancies patients with high corticosteroid treatment, patients of with complicated ketoacidosis and iron overloaded patients who have multiple blood transfusions priorly or before any surgical intervention, and local traumas, burns, skin injuries, and patients with voriconazole treatment. And recently have joined us are very COVID-19 patients who were treated with enormous steroids and antibiotic therapy, and who had a transient hyperglycemic conditions. Okay. So what is the epidemiology of these spores? How they come from? They come from our basic surrounding environments, the compost, the vents and the crops, the foods, everywhere they're present everywhere in our surroundings. So it is always so they are always there in our surroundings. So these spores are being inhalated by the immunosuppressed individual. So these spores, mainly rhizopus, mucor, and leishmania, are the 70 to 80% of major mucormycosis spores are being inhalated by the immunosuppressed individual. And these spores get inoculated or implanted in these different sinuses of the patient and so the lungs. So from there, the etiology, from there the etiopathogens take place, and the further worsening of the condition or mucormycosis pathogenesis takes place. So Rodan et al. Have discovered or made a recent study, and they have explained how this mucormycosis is categorized in overall situations. they have examined around 929 patients. Of overall, there was the underlying condition for the time of infection, usually a diabetes patient, a malignancy patient. The diabetes is scored about 36% of these infected patients. Malignancy patients, organ transplantation patients, deferoxam therapy. This is one of the etiological factor which is important in this mucormycosis. Involves the head and neck area, the pulmonary involving the lungs, cutaneous usually 19%, the rhinocerebral is around 39% overall, and cerebral GI mucormycosis is around 7%. This is how Roden et al. Has postulated his study. So pathophysiology, as discussed, starts from nasal cavity and extension of paranasal sinuses, and they are implanted in the nasal cavity, and there the growth of this fungi goes on. So the primary source or primary site of infection and growth of the infection are the sinuses or the lungs or the area where these spores are getting implanted. So commonly maxillary sinuses are involved, and usually middle terminate is involved. If undiagnosed, there will be a infiltration of bone, and thus extending into the surrounding tissues. So this then the progress via different sinuses or different pathways, or and because of the aggressive angioinvasive property of these mucus species, they can directly invade the cerebral cavity. So how are these mucormycosis angioinvasive property explained? So the mucus species, the mucorales, mainly feed on the iron from heme. The Fe2 plus or the ferric state of the iron, or the iron from the heme is the basic feeder for mucorale mucor propagation, or this is the basic ingredient for spore germination and division. So how is this iron available for this mucus? Is basically directly from the heme or from the iron in a decay host or the diabetic ketoacidosis host, where the acidic medium converts the Fe3 plus or ferrous ion into ferric ion into ferrous ion, which is this decay host has high potential for conversion of Fe3 plus to Fe2 plus, which in turn through oxidase reductase pathway the mucorales take up. And also from deferoxamine. Deferoxamine is a drug which is used for chelation of these iron molecules, and from there, in such cases, directly Fe2 plus is available for metabolism of these fungi. So histopathology, the fungal have the septate and hyphal structures. Mostly they are branching with 90 degrees and irregularly wide. The areas of necrosis and hemorrhage are seen in the biopsy specimens. So basically the symptoms of these patients include nausea, headache, fever, nasal congestion, rhinorrhea, epistaxis, nasal hypoesthesia, facial pain and numbness. History of black nasal discharge and sinusitis is always there. So there is also periorbital pain in extreme conditions where the infection has spread to the orbital cavity. Includes emerosis, diplopia, blurring of visions. The CNS involvement presents with convulsions, dizziness, altered mental status, and gait. And in case of pulmonary mucormycosis, there is respiratory involvement which causes breathing difficulty, cough, and hemoptysis. And in case of gastrointestinal mucormycosis, there is vomiting and abdominal pain. So coming to the signs, so how do we diagnose, or what signs do these patients shows? They are nasal and orbital cellulitis, usually in extreme cases where the orbital cavity has involved following the infection from the sinuses or the sinus cavities. Red and swelling of nasal bridge and skin of the cheek in later stages, and eventually there is discoloration of the mucosal tissues into black areas. This is nothing but a necrosis of these areas caused by occlusion of these mucosals of the peripheral blood vessels. So there is eschar, this is black eschar visible on the nasal or palatal mucosa, and bleeding from the nose is seen. So internal examination, it will give us initially this is important for the dental fraternity for us mainly. How do we diagnose a patient with coming into our office complaining pain from tooth or loosening of tooth, and how do we initially diagnose these conditions? So patient will come up showing periodontal abscesses, multiple periodontal abscesses, ulceration in the oral cavity, or loosening of the teeth, usually with no dental pathologies or no infective background. So there will be initial periodontitis as an oral manifestation, foul odor, mobile teeth, facial swelling in many cases as an initial sign. And in extremely invading cases, there will be exposure of the palatal bone in cases where those were undiagnosed, and we'll see the bone of the palate being exposed. And in severe cases where the infection has spread from the sinuses, from the maxillary sinuses to the orbital cavity, you will see the proptosis of the eye, usually visual loss. You will see chemosis and nystagmus and fixed pupil. Usually there is ophthalmoplegia as well. So how do we evaluate or how do we diagnose a patient where you don't have a condition, where you don't have features of, or you don't find any mobile teeth, or you don't find any periodontal abscesses? So basically, the first sign which a patient shows is a nasal congestion, difficulty in breathing, or there is a nasal discharge from the nasal cavity. So directly in such patients, especially in COVID recovered patients, directly the patient could be sent to endoscopic examination, where the ENT surgeon or the otolaryngologist will pass the endoscope and examine all the sinuses, and followed by, if he could take a sample for culture or histopathological examination, that would be more diagnostic in initial stages where CT or MRI or other aids are not, they might not have a diagnostic imaging in the initial stages. So initially, when the patient complains of any signs of headache, migraine-like pain, radiating type of pain, and nasal congestion, is always intellect to send the patient for an endoscopic examination, followed by culture or microscopic examination. So after that, before going to a diagnostic or a radiographic approach, so CT is always recommended in advanced cases. It will show you the type of bony erosion, the type of obliteration of the sinuses, the extent of the disease. But it has a confinement where the soft tissue soft tissue changes cannot be seen in a CT examination. Where if you want to see the orbital cavity, or if you want to go for a cerebral images, the mode of extending to the soft tissue, CT has its own disadvantages in that. So MRI would be a favorable imaging modality to examine the soft tissue changes. You will see a mucormycosis extension. So you see this axial image where the one side or the left side of the sinus is normal, but the right side there is extreme radiolucency in this, or extreme filled up sinus cavity, where the obliteration of the sinus cavity is seen, and the lateral wall of the nose being involved or invaded from the sinus cavity. And there is another case, another patient showing both of these sinuses obliterated, and the extent of this. If you see this, these sinuses, all the maxillary sinuses are involved, followed by sphenoidal sinuses. All the sinuses are involved, followed by entry of these fungal infection into the orbital cavity. So this is how this fungal infection from the sinuses either way enter into the maxilla, or they invade the maxillary bone, or they go into the orbital cavity, either up or down, through the apex, or maybe through the apex of the orbital foramen, orbital cavity, and apical foramen, or the infraorbital canal, or the infraorbital fissure. So you see this is the mode of the spread from the maxillary sinus into the orbital cavity, or through the maxilla, or through the maxillary sinus into the alveolar bone of the maxilla, where you can see this, the dead or the sequestrated bone, which is seen in the maxillary alveolus. And these are the MRI images which show these are the extraocular muscles of the orbit, where you can see a thickening of these extraocular muscles in severe mucormycosis cases, where orbital extension is seen. These are some of the images of a cerebral mucormycosis, where the entire frontal lobe of the patients are involved. So MRI has an edge in examining or detecting soft tissue changes. You see this in comparison to the other side, these extraocular muscles involved by the mucormycosis are excellently reviewed. And coming to the management part of this mucormycosis, so there is a one world, one guideline given by a European group for its name is European Confederation of Medical Mycology, ECMM. They have postulated mucormycosis treatment modality, and based on 33 countries of United Nations. So they have postulated in Lancet last year as a unique management protocol for mucormycosis. So here goes the treatment. So first, when the patient is diagnosed mucormycosis, or he has any kind of mucormycosis, the first treatment, the first management step is surgical debridement of the areas affected with mucormycosis. So remove all the dead bone or dead tissues whichever are involved, maybe the sinus membrane, maybe the turbinates, maybe the maxillary bone, or maybe the eyeball, maybe the orbital cavity, infraorbital, whatever it is. Remove every bone or every soft tissue part of the involved areas, which until you find the clean margins, debride them properly. All the mucous species, all the mucous should be relieved from the margins. The surgical protocol, surgical debridement is the first management for mucormycosis. It is mainly for three purposes. So, just to disease control, histopathology, and for examination, obviously, and diagnostic purposes, and followed by medical management. So, when and how these medical management goes on. So we are basically we have four drugs of choice for us. There's liposomal amphotericin B and isavuconazole and posaconazole, and also there is amphotericin B lipid complexes which are being used recently. So when and how and what are the doses of these liposomal or amphotericin B? The maximum dose is 5 to 10 mg per kilogram per day for every patient. But remember this thing: the medical treatment has to be very aggressive. Only a surgical debridement will not remove the infection from the patient's head and neck or the whatever, or the lobectomy from the lungs will not remove the infection. Any spores, any ungeminated spores have to be killed or have to be removed from medical treatment only. So if the main thing or the main dialect to be followed is avoid slow escalation of doses. It means give aggressive doses, the starting initially only. So the main dose or the main recommended dose is 5 to 10 milligram per kilogram per day. If there is any immuno or renal compromise or any patient with renal abnormalities, then we take isavuconazole IV or posaconazole IV. But in most of the cases, liposomal amphotericin B from 5 to 10 milligrams per kilogram body weight is recommended, and followed by risk assessment from 3 to 4 weeks, and then we'll see the patient is progressive, if the disease is still progressive or the disease is stable. So this is the amphotericin B and isavuconazole and posaconazole will be the first line of treatment in different patients. So followed by continuation of first line of treatment or change to oral treatment once the patient or the disease is stable. So if the patient or there is progressive disease is seen, then shift to liposomal amphotericin B by increasing the dose to 10 milligrams. Or you can use isavuconazole when there is any deficiency of amphotericin, or mostly in India now they are using isavuconazole or posaconazole for in substitute to amphotericin because of lack of the drug. So rapid spread and aggressive therapy should be followed, and amphotericin B should be administered straight away after when the disease is suspected. So 4 to 6 weeks of amphotericin therapy is recommended presently, and liposomal amphotericin B is endorsed due to its less toxicity as compared to high nephrotoxicity of amphotericin B alone. So surgical debridement includes removal of all the tissues, all the bony area or soft tissue area which are involved, mostly the maxilla, and sometimes usually one side is involved. That hemimaxillectomy can be done, and most of the bone is brittle and dead. It's like sequestrectomy, and you'll see some cases like this, and a direct closure of healthy palatal tissue if there is any palatal tissue available. And if there is no soft tissue available, there are future prospects for reconstruction. Some of them are using a temporalis flap for reconstruction of this soft tissue loss. And orbital accentration and maxillectomy and removal of all the dead tissue is the prime importance, or till your healthy margins or healthy bleeding is seen in these areas. So intracranial involvement includes requires craniotomy and debridement using endoscopic approaches. I will not go in detail about the cerebral management. So All India Institute of Medical Sciences really has recommended treatment organization protocol for COVID-19 cerebral mucormycosis management. So early checklist you have to. I think this is very useful for every clinician or practitioner. They can just have a look. So intracranial involvement includes requires craniotomy and debridement using endoscopic approaches. I will not go in detail about the cerebral management. So All India Institute of Medical Sciences really has recommended treatment organization protocol for COVID-19 infection and practitioner. They can just have a look at it. So early detection at this stage, at the first stage, can enable early treatment and minimize complications. So headache, nasal obstruction by the patient, and even they are not relieved from the pain medicines. Nasal crusting, nasal discharge, as I told you. These are the very important signs, the initial signs where the patient comes up to a otolaryngologist or a maxillofacial surgery's clinic to examine himself. And pain and loss of sensation of face. Usually, patient comes up with ophthalmoplegia in advanced stages, or loss of sensation in the V1, V2 areas, discoloration of the skin face, or the loosening of the teeth, the maxillary teeth, or any ulceration of the palate. This early detection can save a patient's life, and followed by orbital involvement, where patient can see redness in the eye, the double vision, loss of vision, eye pain, or drooping eyelid. So intracranial infection will give us advanced conditions where all the second to sixth cranial nerves are involved. So treatment principles: treatment of comorbid illness, blood sugar control, and COVID illness. So to review COVID treatments to minimize immunocompromised state, first thing to manage to avoid mucormycosis is relevantly managing a immunocompromised state of the patient, managing or keeping a check for the diabetes or the hyperglycemic levels, twice daily evaluation as per medical checklist, confirmation by biopsy or CT or MRI. Pathological signs in initial phase may often be subtle and minimal and may not demonstrate florid sinusitis alone. So always go for the endoscopy or the clinical examination of these patients, where you cannot find a CT or MRI images relevant or not diagnostic. So this is how you this will be a brief introduction or brief knowledge about mucormycosis. And as far as our dental fraternity is concerned, I think patients are coming up into our clinic saying they have a periodontal abscess or they have an ulceration in the oral cavity, and not all these patients will with the periodontal abscess or COVID or mucor cases. So the main intellect idea behind this will be a patient who are hyperglycemic or diabetic previously and who have recovered after a prolonged hospitalization from COVID-19. These are the patients who are bellwethers of mucormycosis. So I think everyone who is coming up with these symptoms or into a dental clinic has to be as a bell ringer for mucormycosis patient, where appropriate diagnostics initially or a referral to an appropriate clinic or appropriate specialty can save the patient's life. So I hope that you will knowledge yourself with some basic necessities of cranocerebral or head and neck mucormycosis.